Yeah, you're sticking with the same group. Good question. Okay, so this, the most important thing is the first sentence, okay? Select a vulnerable population within your own community. Okay, we give you a list of suggestions right here. If you want to go outside this list, it's fine, just let me know. But this is the most common, all these are all found in every one of your zip codes. So essentially, I want you to go back and in your zip code where you live, pick a vulnerable population, and you're going to do a research paper. Not really a paper, it's 10 slides of a PowerPoint, and you're going to present that. Okay, put it in a PowerPoint, and it gives you very specifically what you're doing right here. Okay, here's your PowerPoints. What's the population in detail? What are the health risks, resources? That's what has to be addressed. Okay, here's a suggestion of lists of references, resources that you might want to go to: Census Bureau, National Center of Health Statistics, Department of Health and Human Services. Okay, so don't pick, sorry, one second, sorry. Don't pick homeless people and then tell me what the national statistics on them are. You know, I need it within your community. Does that make sense? So if homeless, you know, there's 10% of the population is homeless. Here's what they need. Here's what they don't need. It's not, this is not to be a generalized assignment. This is something in your community that you want to learn more about. Make sense? So the reason why I present this now in week 4 is this is not an assignment you want to start in week 8. Okay, because you need to do some research. You need to, you know, talk to the health department, find out what the demographics are. You need to get on city websites, get all the information you need. Make sense? So I want to introduce that to you. Okay. Okay.
And what is individual or in group?
That's individual, yes. Your week 7 infectious diseases within your group, but your vulnerable populations is separate. And remember, that is worth 8%. I think it's 8 or let's see. It's a big chunk. So vulnerable 8% right here. Okay, so that is a big chunk of your grade. So if you are kind of, you know, on the cusp or whatever, don't let that be the homework assignment that you don't turn in. Okay. So
you said that one is individual. That's not a group.
Correct.
And that's week
9.
Okay, but
So just
is a group project, right?
7. So write this down. Week 7, you should see this in your modules, but week 7, your second group project is due, infectious disease. I need to know by the end of the week to this week, week 4, what your infectious disease is. Okay. And then it's due in week 7. I'm introducing your vulnerable populations this week in week 4. It's not due till week 9. You still have over a month to do it, but it requires some legwork. So you're going to have to, don't start it in week 8. That's why I'm introducing it today. Okay. We are in week 4. I'm seeing lots of hospice case study grades popping up in the grade book. So thank you. A lot of people have already done it. I'm assuming if you're having any issues about the hospice case study, that you will let me know. I haven't heard from anybody. That was all preloaded. I preloaded that before the term started. You don't have to worry about submitting me anything. These HESI case studies populate into the grade book. You don't need to send me a screenshot or tell me you're done. They populate in there. Okay.
I have a question. So on the grade book, it says that is due May 15th. But
thank you. No. It's in your module for this week. That's what you have to follow. The reason why, thank you, Maria. The reason why I have to put it out a week later is because if you don't turn it in and you're going to do it and you've let me know you're not going to turn it in. You're going to turn it in within the first week for the 10% discount deduction. You can't get back into the case study if I put Sunday as the due date. Does that make sense? So it is due this Sunday. Thank you so much for mentioning that. I forgot to mention to the class this morning. I only have one student last term that said, oh, but the due date said. Everybody else, you know, we go by the modules. Okay, if it's in week 4, it's due week 4. But thank you. I will bring that up to the next class and I'll send out an announcement to my group this morning. So it is due Sunday. The May 15th is for the stragglers who don't turn it in, so they still have access to it. Okay. So that's what we got to do. That's what we have to do this week. And then next week, you have another discussion question, another NCLEX. Remember, you guys, if you're doing NCLEX, please do what the subcategories are in the module. Okay, so the next one, here's your subcategories right there. Okay, if you can't just pick random ones, okay, there's a reason that they're here. Okay, so please use these subcategories. Just because you like pediatrics, don't go pick pediatric questions. This is what we need you to do. Okay. That's next week. Right? Discussion question 2, and then the attestation. You guys did week 3 attestation questions last week, so we don't need to go through those, but we will go through our week 4 attestation questions, which are knowing the 2 parish-based models for faith community nurses. We'll get to, and then list the 5 practice models of home health and hospice. I need to take that out. Interactive lecture. We don't have those anymore. Okay. So with that being said, that's all I want to cover for kind of reminders and information. Does anybody have any questions before we get going? No? Okay. All right, let's get going. What do you guys think about when you think of rural nursing, rural health nursing, and migrant health? How is that different from where you're doing your clinicals now? How is that different?
Not as accessible for people who are in the rural setting, and maybe not for migrant workers as well.
Mm-hmm. Mm-hmm. What are some differences between rural and urban health? What are some challenges for populations in rural America and migrants?
Here in Jacksonville, we've got urgent care centers and ERs like literally everywhere.
Right.
They're probably like within 5 miles from anybody's house. But in rural societies, I guess it could be a lot farther for them to go to get health care.
Mm-hmm. So access might be an issue. What about specialists? Do you think there are a lot of specialists in rural America?
No, we have like a lot of people that I live in Columbus, and we have a lot of people that come from like Southern Ohio and even parts of West Virginia come for specialty doctors because they're not as accessible.
Absolutely. Well, what about kids? Well, do you think kids in the rural setting will always see a pediatrician? Well, who do they see? Maybe a general practitioner that's seeing infants, kids, adults, elders, right? Lack of access to specialists. So rural is much different. Rural health is much different. We talked about, I had to go over all this morning because I had another class with me. So we talked about, you guys know what the chapter outline is, right? That's your PowerPoint, right? Remember, I send you a PowerPoint ahead of time for you to review them to get a basic understanding of what we're going to cover, right? And then we start working with the objectives, right? That we should be able to compare, describe, discuss, define, explain. We should be able to do all these things with the objectives, right? The expectation is that we can answer these questions and articulate those. So that's where we start, and that's where I cover in the book. Okay, so if anybody has not looked at their PowerPoint or their case studies, and this is the first introduction to these topics, just follow along. I have several students in my Monday afternoon class that actually open the book and highlight with me. And that's been real helpful for them. Okay, so as we talked about, access is a problem in rural areas, right? They, as well as farms, they rely on migrant workers to harvest their crops, right? Migrant workers and in rural areas have an incredibly challenging time for many reasons. And we're going to talk about that. Okay, we talked a little bit about the differences in rural versus urban. Okay, urban is your city center, like you said in Jacksonville, you've got urgent cares in every corner. And rural, not the case. They may have one small clinic. I tell the example of Tom and I have a lake house up in Wisconsin, way north in Wisconsin, rural Wisconsin. I had to fly overseas last summer. Well, I was going over there to see the kids. I couldn't find a COVID test. I could not find a COVID test for the life of me in rural Wisconsin. I had to drive an hour into one of the big cities just to get a COVID test. I couldn't get it. There was no access. There was no, the local health departments are a little 2-room building. Half of them didn't even answer the phones, public health departments. I was shocked. But anyway, it gave me just one little example of that gave me a real eye opener. Okay, and you know how I do the highlighting, right? I've already reviewed these chapters. I'm pulling out what we need to know. Okay, based on the objectives, based on what's going to be on your upcoming study guide, and based on what I think is important for concepts for you to know in each chapter. We don't need to read chapters covered start to finish. Okay, so it's not everything I'm skipping through. It's not that it's not important, but it's impossible to retain every chapter from start to finish. Okay, so once again, we talk about poverty. This has come up for the last 3 weeks. Okay, poverty is just as much a factor in rural areas, if not more, than in the urban areas. Okay, we've talked about poverty affecting everything, right? Poverty affects everything from housing to health to clothing to food to education to healthcare access to chronic diseases, right? So this poverty goes right along into the rural and migrant communities. Okay, this is important to know right here. So yes, poverty continues to be a problem in rural areas. However, the groups that are the highest risk groups are these 4. Children, right here, I'm on page 376. So if you get asked, which groups are at the highest risk with regards to poverty in the rural areas, here's your answer. The highest risk groups are children, minority and racial ethnic groups, single parent families, especially the ones headed by women. Okay. The other issue going on in the rural community is the risk of being uninsured and underinsured. Okay. And that's a direct reflection of poverty levels. People can't afford insurance. Okay. Box 22.1 is excellent. Some of the characteristics of rural life. Okay. We've already talked about some of these, but I want you to take a look at those. This is what happens in rural America. Who has worked? Has anybody worked or have a relative that works as a rural nurse or migrant community? I had a student this morning that did, and she said everything in this chapter was exactly what her aunt does. Her aunt works as a rural community nurse.
We have in my work, in the clinic that I work, they have a department that is called migrant health services.
Yep.
So those nurses are not in the clinic. They have to go in the field. We are close to Homestead, where all the Mexicans and Central American not documented people come to work in fields. So they have to go there, and they have like communities, close communities for those people. So
Mhm,
they go there, they go to
Yeah.
the schools,
mhm,
and go to the families.
mhm.
And
Yeah, thanks, Margarita. There's a whole system set up for rural nursing and migrant nursing. It's an
Yeah.
entire system set up. There's some characteristics.
they
Okay,
take to them.
pardon
because-
me.
Huh?
What'd you say?
The nurses take providers
Mhm.
one day
Yeah.
of the week because they live in areas that are just fields of plants, tomatoes, and all those
Yep.
things. They don't have nothing else there.
We had a friend that was in hospice or had been diagnosed with kind of terminal cancer way up in Wisconsin a couple of years ago. And we were shocked to learn that the oncologist comes by every 2 weeks.
They have, for example, a
2 weeks.
that take the mammograms,
Uh-huh. The mobile mammograms, sure.
dental services, and
Yep.
radiologies.
Yeah, the services are very limited. Yeah, we were told the oncologist comes by every 2 weeks. Yep. The other thing about rural areas is people have a poorer perception of their overall health. Okay. They are likely they are less likely to engage in preventative, going for your mammograms, going for breast, for pap smears, going for blood pressure checks, going for preventative stuff. Okay. They're much more likely, which obviously will increase their risk exposure to chronic diseases down the road. They're often more likely to smoke. They report higher levels of alcohol and obesity, right? Much less likely to engage in physical activity, right? Wearing seatbelts, more prone to accidents. They're just less aware of their overall health. That's just the way it is. Right? They're more likely to have chronic conditions. Why? Because they don't engage in preventative behavior. Heart disease, COPD, hypertension, very, very common. Cardiovascular disease, very common. Right? They say that nearly 50% of all rural adults have been diagnosed with at least one chronic condition, as opposed to 25% of the regular population. That's a lot. That's a lot. So when we say one of the biggest challenges in rural health right now, migrant health, is caring for the chronically ill.
Can I
Okay,
say something?
sure.
It's not easy for these kind of nurses
Yeah.
because these people come with different cultures or
Yep.
beliefs.
Yep.
So in the beginning, I remember that they told me that they don't want to consult a provider because they have like chamans, curanderos, and they have a kind of midwife, but they are not studying. They are like parteras that they attend the deliveries. So it's difficult to take them from that.
Right. Margarita, do you want to teach the rest of this chapter? Because that's what we're going to cover.
I am sorry.
No, that's good. That's exactly the next thing we're going to talk. The next thing we're going to talk about is cultural. All the different cultures that you're going to be working with. Right. The other thing about rural is that they typically want to remain in their homes as long as possible. Right. Once they get shipped out to the local regional hospital, they may be hours and hours away from their families. They don't, their families may not have transportation. They may not have the resources to get to them. So these clients want to be cared for in their home as long as possible. Okay. The other thing with rural health and migrant health is the importance of women's health and maternal and infant health. Okay. Obviously, rural populations definitely have a higher infant morbidity rates. Okay. Why? Right. They tend to have a high proportion of racial minorities, fewer specialists. We talked about this, such as pediatricians, OBs, and GYNs. And how many rural communities do we think have a high risk OB doctor? Not many. Not many. You have to go to regional centers for care. The other thing that's common in the rural community is you have an increased, compared to the urban, but an increased amount of women who are victims of sexual assault. Right. And the issue with this, whether it's sexual assault, whether it's violence, whether it's domestic abuse, whether it's child abuse, is what happens in a rural community. Why are people so reluctant to come forward? It's in your PowerPoint. If you looked at them, and it's such a small community, right? Everybody knows everybody. So people are reluctant to come forward because word gets out that this family has this issue, and we call it, in this chapter, we call it the lack of anonymity. Okay, lots of these victims of drugs and alcohol and abuse and sexual assault are very reluctant to come forward. We only end up seeing them in the ER where they're at a crisis level or there's an emergency. Does that make sense?
Yeah.
There's an example in this chapter of a school, I think the school nurse who's at the grocery store, but she's not only the school nurse, she's the labor and delivery nurse, and she's the pediatrician's nurse. And so when she goes to the grocery store, she knows everybody, but they all know her in different settings because she's the rural nurse and she does everything. So for her, there's, absolutely zero privacy, right? Everybody knows her. Okay. Health of children, we just talked about this. Kids are more likely to see a general practitioner than a pediatrician, and sometimes things get missed. I mean, a general practitioner's fine if that's all you have, but if there are issues going on with the kids, developmental issues or all the other issues that could go on as kids are developing, you can't rely on a general practitioner to pick up every single piece of that. Make sense? So some of these issues may not even get picked up till they're in school. Okay, kids are way at risk in the rural settings. And then mental health is huge in the rural setting, right? Huge. A lot of it has to do with economic struggles, poverty, right? And we just said that here, delay seeking care when they have emotional problems until it's an emergency. That goes along with the victims, mental health crises, victims of abuse, child abuse, domestic violence, sexual abuse. Mental health goes right along with it. Delay seeking care, right? And here we talk about same thing, reporting incidents of domestic violence, alcohol, tobacco, and other drugs are very conflicting. When people are related to one another or know each other, they're less likely to report these behaviors. That's really important to remember about rural health, right? Small, tight-knit communities, everybody's protecting everybody. Often they're, you just say, oh, that's the Joneses down the street. That's the way they are, and da. Right? Can you see that happening in the rural community? Okay. And then what kind of occupational environmental issues are in the rural community? Okay. So here's a good list. If you're asked about what are some common issues related to farm workers? Okay. Here they are. There's 8 of them. And we have highlighted number 1 here, which is the most important, is pesticide exposure. Why is that an issue? And how is it related to farm workers? How do you associate pesticide exposure with farm workers?
Because they're working the crops.
Yeah. And lots of things are being used to harvest the crop, right? So I need you to know what these 8 are. Pesticide exposure, heat and sun exposure, we know they're out in the sun all the time. Machinery, accidents, infectious diseases. What about musculoskeletal injuries? Why is that important? Or why is that a common health issue?
Okay.
Why is that a common health
They're
issue?
doing really hard labor.
Oh,
So, you can throw your back out, you can twist your
Exactly.
ankle, a lot of different stuff can happen.
yep. So don't count that out either. Musculoskeletal injuries, respiratory, right? Exposed to lots of different stuff, skin disorders, eye injuries. So know what these 8 are. Okay, these are common health issues related to farm workers. Okay. Levels of prevention. Okay, what are the 3 things I want you to cover in each chapter? Even if I don't get to it, what do you need to cover?
Primary, secondary, and tertiary.
Okay, do you need to cover levels of prevention? What's the second thing I want you to cover in each chapter?
Case studies.
Yep, 2020.
Healthy People 2020. And what's the third thing, at least in the
Case
chapters?
studies.
Yes, but remember the QSIN boxes, the competencies. Those are the 3 boxes I want you to read in every chapter. If you want to do the case studies, I would love that. You have 2 different case studies to do. You have the ones that I provide with your PowerPoint that are provided to me in my instruction preparation. So I call those instructor case studies, and those are great for each chapter. I send you one for each chapter. They're great. They present you with a scenario, and then they give you a rationale of why you have a right answer and why the wrong answers are wrong. So that's great. The second opportunity for a case study you have is in each chapter, right? There's a case study in each chapter where I have provided you the answers from Evolve. So again, I'll say it again, the more case studies you can do, the better. But I need you to review QSIN boxes, level of prevention, and Healthy People 2020 in all the chapters. And then if you review the case studies, that's just an added bonus. It just reinforces your learning, right? Just like the practice application. That's the second answer key that I provide you every week in case you want to do the practice application in each chapter. Okay. And you guys know what I'm talking about, right? Nothing, this isn't unfamiliar to you, right? I know you guys are tired. I know you are. Levels of prevention related to primary health. Teach workers how to reduce exposure to pesticides. Everybody understand why that's primary, right? Prevention. Secondary, conduct a screening such as urine tests for pesticide exposure. Why is that secondary? Screening. Early identification. Tertiary, they already have a pesticide exposure. Initiate treatment for the symptoms of pesticide exposure, such as nausea, vomiting, skin irritation. Everybody understand why those are primary, secondary, and tertiary? There were 6 questions on your exam 1 about primary, secondary, and tertiary. And some of the students I met with, got those wrong. So I need to reinforce with you, you've got to have a good understanding of primary, secondary, and tertiary. You have to. Okay, you can review this box on your own. These are some, we've already talked about a lot of these, but barriers. What are the barriers to healthcare in rural areas? Lack of telephone, lack of transportation, personal transportation, or lack of public transportation, lack of providers, inability to pay, inadequate provider attitudes, language barriers. We'll talk about that now, the cultural part of it. Okay, providers. So our attitudes, insight, and knowledge about rural populations are important, right? We cannot have a demeaning attitude, or have a lack of knowledge about the rural populations. We can't be insensitive to the lifestyle. It may be way different from ours, but that's what it is. We have to be able to be supportive, educated, compassionate, right? If we're insensitive, it's going to generate mistrust, right? And what's the most important thing with any group of people you're working with that you have to start with?
Trust.
Trust. You have to establish trust. Otherwise, it's not going to work. Okay. So, this is interesting read 22.1. Don't need to memorize anything on here. Just giving you different segments of the population. Like, for example, farmers and ranchers. What are their healthcare needs? And what might be their health risks and conditions? Really interesting. Goes through farmers and ranchers, Native Americans, African Americans, migrant workers, Native Alaskans, and coal miners. Really interesting stuff. This chapter breaks out rural immigrants and migrants. Okay. Most of their challenges are the same, but there's a few things that are separate in the migrant lifestyle. Okay. That I want you to be aware of. right? They are have a very unpredictable and difficult lifestyle. In what way? What way? What stands out with a migrant farm worker than a rural resident?
They have to travel.
Yep. They have to travel, and lots of times who are they traveling with?
Their family.
Their family, their kids, everybody. Right? Job instability. Right? What else? So many unknowns, right? Yep. And so it goes through a couple of things. It goes through housing challenge. This is with the migrant lifestyle. Housing, how housing can be a challenge. Maybe they work in poor and unsanitary working conditions, right? So that makes them susceptible to infectious diseases, communicable diseases. With the kids, it's much more dangerous. Okay, here's some other things. Lack of knowledge about what services we have in the community, right? Maybe there's a lack of fluent language barrier, right? Inability to afford care, so maybe they're not going to seek care, right? Availability of services, transportation, hours, mobility and tracking, right? You know, if they've been diagnosed with TB or some kind of chronic illness and they're always moving around to find work, how do you track them? Right? And then, of course, language barriers, discrimination, documentation. Right? I mean, think about the fear here. Unauthorized individuals' fear of getting services in a federally funded or state-funded clinic may lead to discovery and deportation. So they avoid being noticed. Okay. And then the children migrant workers. Okay. Really, really high risk. Okay. Most parents are bringing their families along to try and seek a better future for their kids. Right. But the families these kids are so at risk for developmental issues, lack of education, malnutrition, maybe inadequate dental care, no immunizations, pesticide exposures, overcrowding in their living conditions, right? I mean, they even make a comment here, sometimes it's even difficult to determine the age of these kids. You may have kids as young as 8 years old staying home to care for younger kids. You may have kids 10 years old out working on the farms. All right. And then Margarita mentioned cultural considerations in migrant healthcare. All right. We have to be culturally competent. And there's a whole chapter on culture that we'll go through, but what's cultural competence? What's cultural competence?
Like knowing their practices.
Right. Knowing what the culture is about, what are their values, what are their beliefs, how do you adequately take care of them without making them feel, unimportant, right? They have different religious practices, different values, different beliefs. Okay, for example, they talk about Mexico, multicultural country. Therefore, cultural backgrounds of Mexican immigrants vary depending on their place of origin. Okay. Many indigenous groups in Mexico speak their regional dialect. Mexican immigrants may or may not be able to read, understand, or speak Spanish. They're less educated, fewer economic resources. And from the rural areas, they tend to have more traditional values and beliefs. Okay. What about folk medicine, traditional or alternative health practices? Okay, I need you to, I don't know why this isn't highlighting for me, but I would like for you to have a read at this area right here. Okay, page 385. It's not highlighting for me. I don't know why. Okay, everybody see what I'm looking at? I would like for you to read about that culture on page 385. Okay. What else? Okay, here's your QSIN box. The competency we're talking about here is patient-centered care. In each of these boxes, it always gives a wonderful client-centered care question for you to ponder about what this chapter is about. Okay, so have a look at this. This is an excellent learning tool as well. Okay, here's your case study. I've already provided you the answers to it. Okay, right here. There's always a case study in every chapter, I think, except two in the whole book. But there's your case study if you want to go through that. I've given you the answers with your PowerPoints. Okay, and then nursing care in rural environments. I've already been through this. Migrant and seasonal farm workers. They often develop independent and creative ways to cope, right? They're isolated. They may be far away from home. They have very sparse resources. And they just kind of want to keep to themselves and just work and get a paycheck and take care of their family, right? Okay, box 22.3, let's know this as well. Important, what are the characteristics of nursing practice in rural areas? Okay, think about it. If you're going to be a rural nurse, you have to bring your whole toolbox with you. And what do I mean by that? You've got to bring your med-surg skills. You've got to bring your pediatric skills. You've got to bring your communication skills, your OB skills, GYN, elder care, mental health, right? You may be it. Where if you're working on a stroke unit in a hospital, you're condensed knowing what you need to know about that patient, right? Or that type of patient. Whereas if you're the rural nurse, you need to be prepared to know everything, right? So here's some characteristics: variety and diversity of clinical experiences. Your scope of practice is going to be broadened because you're taking care of clients at all across the lifespan, right? Flexibility, creativity. Certainly you're going to have greater independence and autonomy, right? Your closest peer may be 2 hours away by phone, right? To get a second opinion on something. Okay. Again, here you go. Lack of anonymity. So have a look at this list. Okay. And then here's your Healthy People 2020. These are specific goals, objectives pertaining to residents in both rural and urban areas, including migrant workers. You can read this, but let me tell you something from the last exam. There were many Healthy People 2020 questions, and I was surprised at how many got them incorrect. When you're answering a Healthy People 2020 question, what are the only correct answers? So I'm going to ask you a question. What would be the Healthy People 2020 objectives that pertain to rural and urban areas and migrant workers? Select all that apply. If it's not one of these four in front of you, it's not the correct answer, right? And a few of your Healthy People 2020 questions on exam 1, all the answers were right or correct. For example, what do you want to communicate to new parents? Nutrition, what else? Reproductive. Anyway, you had 4 or 5 answers. All of them were great answers. Great. Yes, of course we want to talk about new parents, but there was only one answer that was part of Healthy People 2020, and it was that conversation about positive parenting. You remember that? A lot of people checked other things, but that wasn't Healthy People 2020. So my message is, if you're getting asked a Healthy People 2020 question, it's got to be in the Healthy People 2020 box. All the answers may look good, and that's why I suggest putting the Healthy People 2020 objectives for each chapter that we're covering on a little index card. Okay? Make sense?
Yes.
Okay. All right. That's it for rural and migrant care. Do you guys feel like you have a little bit better of an understanding of the rural population, migrant population? Any questions? Okay, this is playing tricks on me here. Okay, let's go to chapter 23. Okay, these are the 4 populations we're going to focus on in this chapter. Poverty as a vulnerable population, homelessness, teen pregnancy, and mental illness. These are huge vulnerable populations. And in any community, in every single community that we all live in, all of you, including me, these 4 groups exist. They do. Okay. This is what a lot of students choose to do their vulnerable populations assignment on. I have a lot of homelessness PowerPoints, a lot of teen pregnancy, mental illness, substance abuse. But these are the 4 we talk about in this chapter. Again, your chapter outline is your PowerPoint, right? Here's your objectives. So again, read through, I've highlighted them because I want you to be able to read through them and describe, discuss, develop, explain. This is what you need to know out of each chapter. So if you go back to after the fact and go back to these objectives and say, she didn't cover it, Professor Marble didn't cover it, then you have to go back and research in the chapter what it is. I try and cover everything. I don't have time to cover everything, but I try and get to the bulk of it. Does that make sense? Because this is the important part of the chapter, important pullouts of the chapter. Okay. So these are 4 groups of people who represent members of vulnerable populations: poor, homeless, pregnant teens, and those who are mentally ill. All right. Again, cultural attitudes are the beliefs and perspectives that society values. We have to check our attitudes and beliefs. This is an excellent. I want to read this. Check your practice. We have to examine our own beliefs, values, and knowledge about these particular vulnerable groups. And here's some scenarios. These are just for thought. When you're doing a health screening at the homeless shelter, one of the clients asks you for money for bus fare. What do you do? When you visit the home of an older adult client whose kitchen is covered with roaches, what are your obligations? Okay, when you're making a visit to an especially unclean home and the client offers you food, this is what community nurses walk into, right? What do you do about a pregnant teen who you're a school nurse or you're working in a teen clinic or working in the school clinic, let's say a school where a high schooler comes up and asks you, where do they go to get an abortion? This happens. Okay. How do you effectively advocate for a group of seriously mental ill people who need treatment that there's no options for them in the community? There's a 6-month wait for a bed at a facility. What do you do? How do you help them? There's a lot of really vulnerable people right in your backyard. Are there not? Yes, there are. They're everywhere. They're real close. Okay, so our behaviors in these situations influence our relationships with these vulnerable people. We have to value the importance of these people, try and promote health, respect, and restore human dignity, right? We have to try and help them. If you're working with this population, we want to try and improve their quality of life. We may be working with an individual, a family, or, it's really sad. This is when community and public health nursing gets really, really hard, right? When we have conflicts in values and beliefs, when we're working with these populations, it creates huge conflicts. And these populations are already difficult to work with in itself. And then we have conflicts with how we feel. Okay, let's start with this. Poverty. We're going to go through each one real quick. Poverty. What is poverty? Right? Poverty can be temporary. Poverty can be pretty long-term. Maybe there was a catastrophic event, you know, say with COVID, parents lost their jobs or one did and they had to stay home with kids. And, you know, I saw a lot of families, school families go from not being in poverty to being homeless in a matter of overnight with COVID. Okay. Lots of programs to support. Everybody's heard of the WIC program, but lots of resources to support homeless families, or excuse me, families in poverty. You know, we in the schools went by the McKinney Act, where you qualify, you know, what, oh, that's in the homeless section. Scratch that. Here's some causes of poverty. Okay. Earnings, decreased earnings, increased unemployment rates, changes in the labor force. Lots of things cause poverty. Okay. How does poverty affect health across the lifespan? Right? If you have less access to healthcare, you're going to have a higher rate of chronic illness. If you have less access to prenatal care, you're going to have a higher infant morbidity and mortality rate. Right? Lack of healthcare results in more complex health problems. Okay. Hospitalization rates are greater because the lack of healthcare. And then here's, this is super important, box 23.1. What are the effects of poverty on children? Lots. Okay. Rates of prematurity, low birth rate, birth defects, mortality rates, chronic diseases. So if you get asked a question about what are the effects of poverty on kids, select all that apply or pick one, or, you know, that needs to be one of these. But this, I mean, this is, you should know this. This is common sense, right? You should be able to pick a select all that apply of the effects on poverty on kids, right? Really significant impact on kids. Okay. Then homelessness, second one, understanding it, right? Poverty can lead to homelessness, right? Homelessness, like poverty, is a very complex concept. You know, if you've never been homeless, can you truly understand what it means to be homeless? How do we feel about the homeless people? What do you think when you're, you know, how do you evaluate the concept of homelessness? Right? What do you think it's like to live on the streets? Some of you may have been homeless in the past. I don't know. I know a good amount of people that have been homeless in the past. We may all know people who have been homeless. Okay. What about a young mom with children in a homeless shelter? Right? And you start to ponder, how can people be so poor that they just have no place to go? Well, that happens. What really causes homelessness? You know, what do you do about people on the street that ask you for money? You know, it seems like at every street corner now, every time you stop at a light, is there a homeless person there? I mean, am I the only one who experiences that?
No.
No, and then what about if you stop on the corner at, you know, you stop at a light and it's a mom there with young kids? What do you do? She's begging you for money, knocking on your window, begging you for money. You know, how do you react to the smell if you're walking in a stairwell or an elevator and it smells like urine? And these are all things to consider. Okay. And then obviously the effects of homelessness are definitely correlated with poor health outcomes. We can all understand that, right? And here's some of the following health problems that homeless people may encounter: hypothermia, infestations, diabetes, TB, HIV, trauma, mental illness, increased use of alcohol, tobacco, and illicit drugs. Make sense? I don't know. When you guys are driving down the street in your communities and you see a big homeless camp, what do you think when you're driving by? Do you want to keep driving or you want to stop and help? I don't know. I had, you know, a lot of students who pick homelessness for their vulnerable population. I've had students go down to their homeless encampments in their community and talk to people, talk to the homeless, ask them questions. They put that in their PowerPoints.
A lot
And
of
then-
oh, sorry.
Go ahead.
I work for a home,
Oh,
they needed nurses to do the screening. So for the last 2 years, I did that as like a part-time job. I really loved it. But I noticed like a lot of our homeless people are mental ill people,
Sure.
like majority of them. So they're in and out of the hospitals, because
Yep.
they're having trouble, funding their medication and things like that, and I mean, there's different programs that helps them along the way, but, like the churches take them in on during the winter here, and things like that. But okay, that was it.
Wow, that's cool. And then who is this speaking? I can only see 3 people.
Oh, this is Keisha.
Oh, Keisha, great. That's awesome. Thank you for sharing. That's awesome. That's really awesome. Good for you. Here's your Healthy People 2020 box. Again, you can review that. Okay. And now we talk about being homeless affects across the whole lifespan. Okay. Imagine being homeless when you're pregnant with young kids, adolescent kids, older kids. Everybody's different. Everybody has different needs, right? We must be aware of the unique issues and risks at every age, right? We know that homeless pregnant women are at risk for complex health problems, right? We find that pregnant homeless women are typically younger, unmarried, and uninsured, less educated, and less likely to seek prenatal care, right? And we know that outcomes for homeless women are significantly poorer for pregnant women. Okay. And then the health problems, you can have a look at this, page 398. What are the health problems of homeless kids? It goes through the younger kids, the middle kids, and the older kids. Okay, so I want you to read through this. Okay. Homeless kids have much more serious consequences. So I'm on page 398, talking about homeless and at-risk populations. I would like for you to read that section. Okay, goes through all ages. Okay, and then this is your teen pregnancy section, right? Why do teen pregnancies have such a public health concern? And why are teen pregnancies? Why is there such a big effect on communities with teen pregnancies? What happens? Well, for one, go ahead.
Cycle. It's like a poverty cycle, I mean, if they didn't get any education, they haven't finished their education, it's much harder for them to find a higher paying job, which is much harder for them to, support them and their kids. It's just like a cycle.
Exactly. And they tend to have low birth weight kids that might require hospitalization, might require NICU. They tend to be less educated, so they may need more community resources and mental health resources, and they just have a significantly they're more dependent upon community resources, right? Let's see. Other factors for teen pregnancies. A lot of teens that are pregnant tend to have been sexually abused during their lifetime, right? They say that up to as high as 60 to 70% of girls that are that are teenagers and get pregnant have been sexually abused, right? Adolescent girls with a history of sexual abuse are at risk for early initiation of sex, right? Which is less likely to use birth control, which results in pregnancies. Okay. And then there's always the young men in paternity. Let's say you have a teenage dad, same boat, less educated. It's hard. It's hard for both the teenage pregnant mom and then the young men. Okay. Then one of the things you might be dealing with the teenage pregnant mom is abortion versus adoption. You may be right in the middle of that conversation with these moms. So got to think about that as well. You have to be resourceful. Know what resources are available to them in the communities, right? And then we definitely know that pregnant teenagers are considered high risk, right? They tend to get prenatal care late, if any. They tend to have low birth weight. Their nutrition is terrible during pregnancy, right? So obviously they're going to be considered high risk. Okay. And then again, we're still with teen pregnancy violence. Teens are more likely to experience violence during their pregnancies than adult women, right? Right. So violence in pregnancy has been with teen pregnancy has been associated with an increased risk of substance abuse, poor compliance with prenatal care, poor birth outcomes. Okay. Makes sense? Really a tough situation. Nutrition is always an issue with the teens. Infant care may be an issue. They're young, they're uneducated, they don't understand what it's like to care for an infant. So here's something I would like for you to know. How do we promote interactions between teen mother and her baby? Okay, so please read through this list. This is all what you want. What you want to be observing in a mom. The most important thing, if you're the public health nurse doing a community visit to a new parents or teen parents, what's the first thing you want to make sure that's going on? You want to make sure that these guys are bonding. Okay. Is the mom, is she reacting to the baby's needs? Okay. Is she talking to the baby? Is she feeding the baby? Is she attending to the baby? Is she bonding with the baby? Okay. So we know that babies cry for many reasons, right? Diapers, food. Is she attentive to that? Okay. She liked to play and talk and all that. So very, very important to observe with regards to interactions between a teen mother and her baby. Okay. Oh, and then mental illness. Okay. And then here's your at-risk populations for mental illness. Obviously, kids and adolescents are at risk. And here's why it goes through each section. So I just need you to know what the categories are. At-risk populations. One is children and adolescents. You can read through this, and I think this is one of the objectives. Why are they at risk for mental illness? Well, let's talk about that for a sec. What's happened in the last 2 years with COVID? What's happened to kids and adolescents? Why have they become at risk for increased mental illnesses?
Lack of social interaction.
Isolation. Lack of social interaction.
They're not having like one-on-one like interaction versus like what we're doing now. They've been doing this if they're on like code restrictions or like
exactly.
if it's an outbreak in the classroom.
Exactly. Been a tremendous impact from tremendous mental health impact on kids the last couple of years. Tremendous. Suicide rates are up. I mean, waiting lists are months and months long for mental illness treatment. It's really sad. Okay, so adults are also at risk. Adults with serious mental illnesses are at risk. So just here's your case study for this chapter. Okay. If you want to go back and review the answers I sent you, this is actually a good case study. Older adults, why are they at risk for mental illness? So go through those children, adolescents, adults, and then older adults. Okay. Okay, this is an excellent, I already have this printed out. This is in my little book, just in case I need it. Friends, family, nothing you have to memorize, but this is an excellent list of resources for examples of sources of information to help with people with mental health. Really, really good list. Okay. And then levels of prevention. Okay. I think this is the chapter that we talk about. Hang on, I just want to. Levels of prevention. Okay, related to mental health. This is a good box here to review because it has several examples under each. All right, so primary, educate, teach stress reduction, parental education, support to caregivers, screenings, right? I mean, so have a look at this. Okay, you know what primary, secondary, and tertiary is at this point. If you don't understand it, you need to reach out to me after reviewing these boxes. Okay. And then there's your QSIN box, your competency that's being reviewed in this particular chapter is client-centered care. It gives an excellent client-centered care question with some questions to ponder. Okay. What do you truly believe about being poor? What do you personally know about being poor? Have you ever personally been poor? What really causes poverty? Just questions to ponder. Okay. I don't need to know that. Okay. So there's your 4 very vulnerable populations. Okay, the last chapter I want to cover is, at least for last week, is this alcohol, tobacco, and other drug problems in the community. We can go through this pretty quickly because it's about a lot of types of drugs, but knowing the effects that alcohol, tobacco, and other drugs have on your community. If you're a public health nurse, community nurse, you may be actively involved with issues regarding alcohol, tobacco, and other drugs. Okay. So again, here's your objectives. Okay. Okay, what do we know? Substance abuse is the leading national health problem, right? Causes more deaths, illnesses, and disabilities than any other health condition, right? Considerable death and disability are caused by the use of alcohol, tobacco, and illicit drugs, right? We know it affects everybody, right? Addiction affects all ages, races, sexes, segments of the society, doctors, nurses, lawyers, engineers, CEOs, everybody, right? And I know of all, I don't know this, but I'm thinking that we have all known somebody or family member, friend, coworker that has had issues with substance abuse or addiction. It's tough. It's really tough. Okay. We know that the scope of these problems causes great health risks. All right. Okay, what are some types of drugs? Okay, we have psychoactive drugs. It goes through what these are. Okay, what I'm needing you to pull out of this chapter is what are the effects of alcohol, tobacco, and other drugs have on your community? Okay, I don't know what kinds of drugs there are. You don't need to memorize every drug listed in this chapter, but knowing what categories of drugs people might use. Okay, the first is psychoactive. Okay, what's listed under psychoactive might be depressants and stimulants. Okay, for alcohol, you can, what are we saying about alcohol? Alcohol is the most oldest and widely used psychoactive drug in the world. Okay, so we're still under psychoactive depressants, stimulants, alcohol, tobacco. Okay, tobacco is the foremost preventable cause of death in the United States, resulting in about 480,000 premature deaths and more than $300 billion in healthcare costs. That's incredible. Okay. Caffeine is discussed in this chapter. Caffeine is one of the most widely used psychoactive drugs in the world. Right, and it goes through what some of the side effects are if you use higher doses of caffeine. And it actually has a table here, table 24.1, if you want to know how much caffeine. Of course, I went and looked at tea because I drink tea all the time. Right, and how much caffeine that had. But you look at some of these things, Red Bulls and Monsters, and lots of caffeine. Illicit drug use. What kinds of drugs are we talking about? Opioids, right? Heroin is the most commonly used opioid, right? And we know right now there is an epidemic that just keeps getting worse and worse and worse with opioids, right? We hear it about it on the news all the time, right? I mean, the percentage of increase is tenfold than what it used to be. And I just read a recent story that we have had the most overdose deaths from opioids ever since we've been tracking them in 2021. And 2022 is already on target to be bigger than 21. Okay. And then cocaine. They talk about amphetamines. So I just need you to know the categories. Marijuana, another issue. Lots of states, it's legal now. However, there are some issues. So read through the marijuana section. Okay. Street drugs. Okay. Another category of drugs. Predisposing contributing factors. Genetic factors. Okay, what's our role? What's our primary prevention, the role of the nurse? This from 423, where it starts with primary prevention. I'm just going to click down here for a minute. Show you. Secondary, 425. And tertiary comes up on 428. This is the most comprehensive section in the whole book that will talk to you about primary, secondary, and tertiary. Okay, so if you want to read through these sections, I know we're in the chapter of alcohol, tobacco, and other drugs, but this is the most comprehensive review that you'll get of primary, secondary, and tertiary. All right, so everything that comes between primary and secondary in this book, check your practice. How do you set up prevention, substance abuse prevention? Okay, that's all in the primary. How do you do drug education, right? This is still primary. How do you determine the relative safety of a drug? Primary. Okay, levels of prevention is put in here. Okay, primary, secondary, tertiary. Okay, and then we haven't even got to primary yet, or secondary. Here comes secondary. Okay, what do we do in secondary? Assessing for alcohol, tobacco, and drug problems, early identification, how to assess socioeconomic problems resulting in substance abuse. So how to assess risk factors, right? So here's screening. What questions do you ask? This is your screening. Have you neglected family obligations? Do your parents or spouses or friends complain about you using drugs? So everything in this section is secondary. Drug testing. Okay, there's your Healthy People 2020 box. Okay, still in secondary. Drug use during pregnancy, use of illicit drugs. Okay, codependency. And then we get into tertiary, right? Let's say they have an issue. In tertiary, we're looking at detox, addiction, treatment, recovery, smoking cessation programs, support groups. Okay, and what's our role? Okay. So anyway, that is a summary of that chapter. Does that make sense? It really is a good breakdown of primary, secondary, and tertiary. I know it's specific towards alcohol and drug use, but it's very particular in what each level assesses. Make sense? Okay. Let's shift gears and talk about parish nursing. What do you guys know about parish nursing?
Nothing.
Okay, let's start. Anybody know a parish nurse? Faith community nurse. Anybody know one? I had somebody this morning that I think their sister was one. So anyway, what do we think about a faith community nurse? What do you think? What do you think she does? She. Okay, let's find out. I don't know why I don't have this highlighted. So there's your objectives. Okay. So a few things we need to know from this chapter. Okay. First, we need to know the difference between religiosity and spirituality. Okay. So when we think about this chapter, think about it can be any kind of religion. Okay. Whether you're Muslim, Catholic, Episcopalian, Lutheran, Baptist, doesn't matter. Okay. Parish nursing applies to all of this. Okay. Whatever your own religion is, wherever you worship, all of it applies. Does that make sense? This isn't about any one religion. Okay. There's parish nurses or faith community nurses in all these religions. Okay. So when we talk about religiosity, we're referring to our beliefs, my beliefs, your beliefs. Okay. My religion is Catholic. Okay. I attend a Catholic church. So somebody else might be Baptist and attend a Baptist church, on and on. Does that make sense? So religiosity is what we believe about our own religion, where spirituality is the big picture. You know, what are your attitudes and beliefs towards or related to the transcendence or the non-material forces of life and nature? What are your feelings about God? What is your big spiritual thought process? That's the difference between religiosity and spirituality. Okay, that's one thing we need to know. Faith community nursing, parish nursing, all used. They all mean the same. Okay, but a faith nurse is a community nurse. She's different type. And what do we think she does? What the difference between a community nurse and a faith community nurse is the spiritual aspect gets added into the care. Okay, so the faith community nurse is usually directed by the leaders of the congregation. What do they want the faith community nurse to do? Okay. Here's some examples. Visiting in the home, providing meals to families in crisis, returning home from the hospital, participating in quilting circles, holding regular grief support groups, prayers and healing services. Okay. And then there's two types of parish nurse models that we need to know. One is the congregational model and one is the institutional model. So you may be given a scenario about this, and you have to ask which model would we use. Okay, so here it is in box 29.1. It's really simple. Congregation-based model is you are working simply within the congregation. Okay, all your activities involve congregation members. Okay, you're accountable to the congregation and the governing body. Where institution-based model is you collaborate. You work in partnership with outside agencies such as maybe hospitals, medical centers, long-term care establishments, educational institutions, so that they can provide additional resources to your community. Make sense? What questions do you have about that? Because we do need to know that. So for example, institution-based model, you may be contracting with a long-term care establishment to do visits, right? Or urgent cares to do visits, or hospitals to take patients in. Make sense? Okay, so obviously the goal of faith community nursing is to develop and sustain health ministries within faith communities. Okay, health ministries, what's a health ministry? What are examples of health ministries? They may be support groups, grief groups, volunteer health fair, whatever that the governing members of that congregation want to see as far as health promotion, which is a lot of what parish nursing is, health promotion. Okay, but like I said at the beginning, it's a spiritual dimension, which is central to the practice of parish nursing. Okay, we're trying to embody physical, psychological, social, and spiritual dimensions. Okay. And again, levels of prevention, you can go through page 516. Okay, this is an excellent box because it gives numerous bullet points in each of the 3 levels. Really good box. And then one of the things that faith community nurses often participate in is maternal and infant health. Okay, so like we talked about with teen pregnancy, right? One of the health ministries usually in a congregation is that the faith nurse visits families immediately after birth, not just teens, but any new family, right? And they do assessments of their parenting skills. They look for parent bonding, right? They reinforce holistic spiritual reflections on these life transitions. Okay. And there's a few other examples of what they do as well. Augment community prenatal classes, facilitate support groups. But I want to mention the top one, which is they really do an assessment of parenting skills, bonding, make sure everything's going okay. Okay. And then there's always issues in any kind of, whether it's school, your specific community health nurses, school nursing, hospice nursing, home health, faith community, occupational, there's always these issues. Okay, you're going to have professional issues. You're going to have ethical issues. This is across the board. You're going to have professional issues, ethical issues, legal issues, and financial issues. Okay, for example, look at an ethical issue. If you're dealing with working with somebody in the community, what is the ethics of end of life care? Right? Legal issues. Do you have the right to do the following? All these kinds of community nurses all have their different scope of practice. If you're working as a hospice nurse, you're going to have a different scope of practice than the home health nurse, than the faith community nurse, than the school nurse. Okay, so you have to be well aware of your scope of practice. Okay, so that's your faith community nurse. Do you have any questions about that? Okay, and lastly, let's talk briefly about the nurse in home health and hospice. That is, they talk about these nurses in a very similar environment. Okay, home health and hospice. That's why it's together in this chapter. Okay, so you read through your objectives, and that's what we're going to try and cover in this chapter. So I want you to go ahead and read this section on your own when you go back and review this material. It's on page 524. It gives you an excellent idea of what home health is. Okay, what is home health? It's disease prevention, health promotion, and episodic illness related services, right? And mostly provided in clients' places of residence. Could be an apartment, could be a trailer, could be care home, could be a shelter, could even be in a car. or any other place where somebody lives. Okay. Optimum location for people to receive cares in their home. Okay. And then when we're providing care, if we're doing home care to an individual, we're also caring for the families, right? We may be teaching them how to give injections. We may be teaching them how to do wound care, teaching them hygiene, meal prep, right? So much care is now provided in the home that used to be provided in the hospital. So much of it is in the home now. And then here's your levels of prevention, primary, secondary, and tertiary as it relates to home care. So please have a look at this. Right. And if nurses practicing in community health, home health especially, I've already talked about this, are practicing autonomous. Oh my gosh, I'm not gonna be able to say the word autonomously, right? They're practicing with little structure. I mean, they have to be able to bring, like I said, bring all your tools, your communication, your organization, your time management, right? You may be just bouncing from home health visit to home health visit to home health visit, right? Your creativity, your organizational skills are critical. Okay. Typically in home health, you don't have all the resources that you typically find in a hospital. Right. So oh, here it is right here. You need to have good organizational, critical thinking, communication, documentation, all that needs to be, you need to have all that. Right. And when you're working in a home, you're a guest. Right. You're trying to establish partnerships with the family, trying to establish trust. Safety is of the utmost concern. You don't really need to go through the history of home health. We do need to know, here's what we need to know. This is our second attestation question, is what are the practice models? Okay, here are the 5 practice models in home health. Okay, first one is population focused home care. We're starting on 526, 5 practice models. We need to know this. Population focused home care. That means you're caring for a certain population. Okay. For example, you may be caring for young kids, you may be caring for diabetics, you may be caring for chronically ill elderly. All right. It's a specific population focused home care. Okay. Second, transitional care. What is that? Just what it says. You're caring for clients moving from one place to the other. Okay. They may be going from their home into the hospital. They may be going from rehab home, assisted living to long-term to assisted living. They're transitioning. Okay. Nurses can play a significant part of facilitating a smooth transition. And then you have home-based primary care. Okay. Home-based primary care is another form of home care delivery. The emphasis in these programs is on delivering primary care in the homes of people who have difficulty getting to their doctor's office or to a clinic because of whatever's going on, health problems, functional issues. Okay. These have been called house calls. All right. Then you have your home health. Okay. And this is divided into different organizational structures, but these are your home health visits. This doesn't have anything to do with people not being able to get there. This is care we can provide in the home. Okay. Then the last one is hospice. And what is hospice? Palliative care, right? Hospice is palliative care of the very ill and dying. Okay, what's our job? Reducing distress from physical, emotional, and spiritual symptoms. So this is where hospice is introduced on page 528. Okay, so I'd like for you, I have highlighted this section on hospice. I'd like for you to read this section. It gives a very nice overview on what hospice nursing is, page 528. We all know what hospice nursing is, right? Hospice nurses are all of our guardian angels, right? The great thing about hospice nurses is with all their additional education, they can work with the whole family. Yes, they have a client they're working with, but they are masters at dealing with the whole family. How to bring family members into the process, how to bring family members that don't want to be in the process into the process. Okay. And then what happens in hospice when you're trying to care for a dying child? Really tough stuff. Okay. Okay, I had many kids over the years in my 20 years of school nursing that ended up in this situation, that were very severely chronically ill, that, you know, went into hospice, and really, really, really tough stuff. Okay. And then again, hospice nurses have their scope and standards of practice. Okay. And nursing roles in home health, hospice, and palliative care, kind of a summary. So here's some of the roles that we potentially are fulfilling. All right, advocate, educator, mentor, researcher. Okay. And then the Omaha system is mentioned here. This is a really kind of a collaboration system where everybody, this was the initiation of the process of communicating with each other, collaborative practice. Hospice nurses communicated with the doctors, who communicated with the nurses. Okay. It was a problem-solving process. Okay, it developed a structured and comprehensive system that could both be understood by and used by members of various disciplines, collaborative practice. Right? Everybody added their expertise, and then decisions were made or problems were solved through the process of everybody being involved. Multidisciplinary approach. So that's what the Omaha system, it's been in place since the 70s. Right, and then professional development and collaboration. All these different types of community nursing require certain levels of education and roles. They all look different. Okay. And that's it. That's all. Well, accountability and quality management. This is more of your QSEN, evidence-based quality and performance improvement activity and client safety, right? So the only thing I want to mention here is, I know we think quality improvement, quality assurance in the hospital setting, but quality improvement and quality assurance is just as important in the community setting. Okay. Quality improvement activities are a crucial part of nursing care, especially in the community. We do the same thing in the hospital, monitoring care, seeing opportunities to improve care, developing guidelines to improve care, collecting data. This is all evidence-based practice, right? We do it in the community setting as well, not just in the hospital setting. Always looking for the best way to do it. Okay. Oops. And then again, you have your legal and ethical issues with hospice nursing as well. Legal, ethical, professional, financial. Okay, and here's your Healthy People 2020. All right. And that's all I need to cover. That's all we need to cover in this chapter. I know you guys are absolutely exhausted. So I know we covered a lot tonight. Do you feel more knowledgeable about faith community nurses and hospice nurses and home health nurses and what the rural population is and vulnerable populations? A lot of information. Okay. So what I suggest you do when I get you your study guide too here this week, I suggest you go through it and just, again, like I said, with the first one, highlight what we've covered, right? Most of it should be covered. We still have next week to cover week 5. Most of it should be covered in weeks 3 and 4, but there's a section that will be blank because we haven't covered it yet. We'll cover that next week. Okay. Does that make sense? Is this helpful? Again, I know you guys have a long day. Let's do the attestation questions real quick and then get you guys going. How's that? And the first one is, I think the first one is the difference between congregational and institutional parish nursing. Right? Is that what it is? What are they? Congregation, you're just dealing with your congregation. You're accountable to your congregation only.
No, the first one is the 2 parish-based, and the faith community nurses.
The 2 models, right? Yeah. And then institution, what is that? That's collaboration. That's partnerships with outside of the congregation, right? Hospitals, urgent cares, educational facilities, transportation facilities. You know, all those little vans that you see driving around, taking elderly people to their appointments and stuff. That's part of the partnership with the community. Make sense? Okay, that's number 1. Number 2 is your 5. What is it? Your 5 practice models. Oh my gosh. Let me think. Population focused care, right? Where you're taking care of a specific population. The kids, the elderly, the diabetics. Right? Next, what's next? Transitional. One place to the other. I'm kind of helping you guys along here right now. Nobody probably has a brain anymore right now, right?
I put official, private, and voluntary combination, hospital-based, and proprietary.
For what? That's pretty big. For what?
For the second one, that's what I found in the slide.
Wait, what are we talking? Which question are we on, Shannon?
Are we on 2?
Yeah, it says please list the 5 practice models for home health and hospice community nurse.
Mm-hmm. So we're going through the 5 models, right?
Yeah.
And what were they?
Official, private and voluntary, combination, hospital-based, and proprietary. No? That's what I found on the slide.
That's what I got too.
Okay, I'm going back through the population, the transitional model, the home care, home health, and hospice. Those are the 5 that what page are you looking on, Shannon?
It was in the slide. Hold on 1 second. I can pull it up. It was
I got
on the chapter.
485.
I pulled it from the slideshow for chapter 30 on slide 9.
Page 485 in the book.
It says that it's figure 30.1 in the book.
Okay. Let me go back and review that, but in the meantime, I'm going to go through the 5. I want us to put in the 5 models. Put whatever you want in, okay, for right now. But those are the 5 practice models that I wanted to cover in the book. So I need to go back and review slide 9. Is that in the PowerPoint?
Yeah, actually, hold on one second. Now that I'm looking at it, it says administrative and organizational structures.
Yeah, that's your home. That's your home care.
Yeah, so I may have done that incorrectly.
Yeah, so that's your third one.
Well,
That's
it
your
says
home
under
care.
description of practice models.
That's your home care. Because the home care has the organizational structures.
Okay. What were I'm sorry, what were the 5 that you had mentioned? I'm just gonna write it down.
Oh, that's okay. Hang on. We're gonna go back here. We are in home health, right?
Yes, ma'am.
Okay, let's go back and find our 5 practice models. Here you guys go, right there. Right in your chapter outline. First is populations. Home care of the dying child is with hospice. Okay, so there's 5. 1, 2, 3, 4, 5. Here's your 5.
Well, thank you for that clarification.
Does that help?
Yes, ma'am.
So there's your 5 right there. Okay.
So what did we put for one more time? I'm sorry.
Okay, somebody, who's talking?
Keisha.
Keisha, somebody tell Keisha what we put for number 1.
Sorry.
No, that's fine.
Congressional and institutional, is that what it was?
Congregational and institutional.
Congregation.
Yep. What is it, Shannon? What's congregational? You're accountable to who?
Oh, man.
You're accountable to your congregational.
Just for congregation.
Yes.
It's the
thank you.
congregation.
Yep. I can't remember. What's the next one?
Partnership outside of the congregation.
Yep.
The
And the other one's the institutional model, which is what? When you partnership with communities, partnership with different resources in the community. So let's say what the church wants you to do is outside of your scope of practice. So now you're going to have to partner and collaborate with the community to get those services in. Make sense? So if they say to you, we want to take care of the elderly in all the aspects, every aspect. Well, what's a priority? Well, they may only allow you to do 2 or 3 things with the elderly, but not any direct care. So you have to bring in wound people, you have to bring in PT, you have to bring in OT. Make sense? That's your partnership with the community. We got that?
Yeah.
Everybody? What time is it? 7:51. You want 9 minutes of the gift of time? I'm just trying to get you guys done. Okay.
Thank you.
Okay, you're welcome. Listen, have a good week. Reach out if you need anything. Yeah, you know how to find me. Just reach out if you need anything. Just get some rest tonight. You done good. Been a long afternoon and evening for you guys. You done good. Proud of you. Really proud of you. Okay?
Oh, thank you.
You're welcome.
Thank you. Good night.
Hang in there. Good night, guys. I'll stay. I'll
Thank
stay
you.
on. You're welcome. I'll stay on here. In fact, I know I need to stay on for, hang on.
Professor
Yes.
Marvel,
Yes.
are you gonna have more times you said for people to review their exam?
Yeah, we need to come.
I'm
Yeah.
sorry, go ahead.
No, that's okay. It's going to be towards the end of the week. For what do you got going towards the end of the week? What about Thursday, Friday?
Thursday work in class, and Friday lab and work. I mean, I can step away from work to take a minute
It'll
to go.
probably
to
take
my
us a half
class.
an hour. I need 30 minutes.
Oh, I can just do it on my lunch then.
Okay.
On a Thursday or Friday. It doesn't matter
Okay,
what time.
what time's your lunch on Thursday?
I can make it whenever. I can make it at 12 or 12:30, whatever time you say that you're available. I can make. my
I'll be
lunch.
available for you whenever Thursday. Why don't you shoot me an email and tell me what
Okay.
time you're going to lunch? I'll get on and we'll do your exam review.
Okay.
How's that? And
Yep.
then, are you Eastern time?
Yes.
Okay, so I'm I'm going to be Central time right behind you. So use whatever time you will have lunch. I will maybe just let me know Wednesday
Okay.
and I'll get on anytime Thursday to meet with you.
Okay. Thank you.
Okay? All
All
right.
right. Good night.
All right. Good night. Bye. Jabari, do you need something?